And also, I hope you guys are preparing well for the upcoming entrance. So just believe in yourself. The final days, it's more about staying positive and oriented. It's not just about the number of revisions. Have this perspective in mind, and those who stay positive and oriented will do much, much better than those who are constantly worried about the result or output. Hi, hope you guys are all doing good. For the past couple of days, it's been very cool and it's raining cats and dogs in here. So, how is climate at your place? So, let's continue with our paper discussion videos, part 4. I hope you guys are all ready. So, first, we'll discuss about VVM. So, what's this VVM? Vaccine vial monitors. As you can see in the illustration below, there seems to be a colored strip, and this contains a heat sensitive material which registers cumulative heat exposure. And once it changes to a specific dark color, as you can see in the top right illustration, vaccine has to be discarded. So vaccine vial monitors, VVMs, this is a label containing heat sensitive material which is placed on a vaccine vial to register cumulative heat exposure over time. And the combined effects of time and temperature cause the inner square of VVM to darken gradually and irreversibly. If that's the case, it has to be discarded. The vaccine vial has to be discarded. Okay, now let's move on to the next topic. Regarding sanitizer, hand wash, hand hygiene, those are the keywords which I received. We'll review some literature based on the one which is available in WHO website. And if you need any further information or clarification, you can just get back in the form of comments, right? So as you can see, we have 5 protocols or 5 movements for hand hygiene as stated in WHO website. First is before touching the patient. So you have to go with hand washing or hand hygiene without any doubt. Whether you have to use soap or sanitizer, we'll discuss that in the next slide. So first, before touching a patient, go for hand hygiene. And number 2, as you can see, before cleaning or before any aseptic procedure, go for hand hygiene. Number 3, after body fluid exposure risk, obviously you have to go for hand hygiene. And 4, after touching a patient, and 5, after touching patient surroundings. So any of these criteria, we have to go for hand hygiene without any doubt. And this is some specific information available in WHO website. So if you observe various indications for hand hygiene, point A, wash hands with soap and water when visibly dirty or visibly soiled with blood or other body fluids or after using toilet. So don't go for sanitizing or using a alcohol-based sanitizer tank. It's better to wash with soap and water as mentioned in point A. B, if exposure to potential spore-forming pathogens is strongly suspected or proven, including outbreaks like Clostridium difficile, hand washing with soap and water is preferred means. Now, I think this is one of the options which you received or which you got in your exam. C, use an alcohol-based hand rub as preferred means for routine hand antisepsis in all other clinical situations described in items D, A to F, as you can see below. If the hands are not visibly soiled. If the hands are not visibly soiled. So this is what I wanted to highlight. If the hands are visibly soiled, go with soap and running water. There is no doubt in it. And if the hands are not visibly soiled, you can go with alcohol-based hand rub. And also you can go through the rest of the points as per your convenience, right? I hope this information is helpful in answering your question. Now let's move on to the next topic, necrotizing ulcerative periodontitis. Observe the clinical image carefully, along with interdental bone loss, along with the presentation of NUP. You will also find another important clinical characteristic finding which is relevant to that of HIV. Can you identify what that is? So I'll get back to this question at the end of the slide, but before that, let's review some information regarding NUP. So a necrotizing ulcerative rapidly progressive form of periodontitis occurs more frequently among HIV positive individuals, although such lesions were described long before onset of AIDS epidemic. Necrotizing ulcerative periodontitis may represent an extension of NUG in which bone loss and periodontal attachment loss occur. And NUP is characterized by soft tissue necrosis, rapid periodontal destruction, and interproximal bone loss, as evident in this illustration. And lesions may occur anywhere in dental arches and are usually localized to a few teeth, although generalized NUP is sometimes present after marked CD4 plus count. After marked CD4 cell count is depleted. Bone is often exposed, resulting in necrosis and subsequent sequestration. NUP is severely painful at onset, and immediate treatment is necessary. Occasionally, however, patients undergo spontaneous resolution of necrotizing lesions, leaving painless, deep interproximal craters that are difficult to clean and that may lead to conventional periodontitis. Therapy of NUP includes local debridement, scaling and root planing, in-office irrigation with an effective antimicrobial agent such as chlorhexidine gluconate or a povidone iodine or quetiapine solution, and establishment of meticulous oral hygiene, including home use of antimicrobial rinses or irrigation. And along with that, we have some additional information in the form of dosages. In severe NUP, antibiotic therapy may be necessary but should be used with caution in HIV-infected patients to avoid opportunistic or potentially serious localized candidiasis or even candidal septicemia. If an antibiotic is necessary, metronidazole 250 milligrams, 2 tablets taken immediately, and then 2 tablets 4 times daily for next 5 to 7 days is drug of choice, metronidazole. And prophylactic prescription of a topical or systemic antifungal agent is prudent if an antibiotic is used. So you can expect an assertion and reason type of questioning in this particular context. So why do you go for prophylactic antifungal agent? So there can be chances of opportunistic infections in the form of candidiasis. So regarding the question which I asked at the beginning of this slide, linear gingival erythema. Isn't that obvious in this clinical picture? Yeah. Now let's move on to the next topic. Dengue caused by which virus or the causative organism? Let's review some information. This we already discussed the same in our E-classes and also in our study club discussions. Dengue fever is debilitating and sometimes hemorrhagic fever. Hemorrhagic, one that is associated with severe or extensive internal bleeding. The disease is caused by 4 slightly different types of viruses from genus Flavivirus that is designated as DEN. The 4 antigenic types of dengue virus are DEN 1, 2, 3, and 4. The dengue virus is transmitted to humans via bite of mosquito, as you can see in this illustration. The principal mosquito species is Aedes aegypti, right? I'm sure you're familiar with this name. Okay, now let's move on to the next topic. Bone graft properties. So I come across some terms like osteoconductive, osteoinductive, osteogenic. So let's review some information regarding this bone graft materials or bone graft properties in line with these terms. So as mentioned in Karanza, bone graft materials are evaluated based on their osteogenic, osteoinductive, or osteoconductive potential. We'll also look into the meanings of these terms, but before that, an ideal bone graft substitute should be biomechanically stable, able to degrade within an appropriate time frame, exhibit osteoconductive, osteogenic, and osteoinductive properties, and provide a favorable environment for invading blood vessels and blood-forming cells, including bone-forming cells. And along with that, what are these terms? Osteogenic, osteoinduction, osteoconduction. So osteogenesis, as the name itself indicates, genesis or formation of bone. So osteogenesis refers to formation or development of new bone by cells contained within the graft material. Whereas osteoinduction is inducing bone formation, is a chemical process by which molecules contained in the graft, such as bone morphogenic proteins, convert the neighboring cells into osteoblasts, osteoinductive. And these neighboring cells, which in turn convert into osteoblasts, have the potential to form bone, so osteoinductive. Osteoconduction is a physical effect by which the matrix of graft forms a scaffold that favors the outside cells to penetrate the graft and form new bone. Conduction, osteoconduction, right? Now, I hope this information is helpful in answering your question. If you need any additional information, do let me know in the comments section. Okay. Now, Let's move on to the next question. So there seems to be a question on labial bow and which size stainless steel wire is used, if I'm not wrong. So different types of labial bows for your information. So those with U-loop, you have short, long labial bows, split labial bows, reverse labial bows, and fitted labial bows. In labial bows without U-loop include Roberts retractor, Mills retractor, high labial bow with apron spring. So if we further extend our discussion into different labial bows and the corresponding gauges or sizes of the wires from which they are fabricated. Short and long labial bow, they are fabricated from 0.7 mm or 21 gauge stainless steel wire. Split labial bow also from 0.7 mm or 21 gauge stainless steel wire. Fitted labial bow also from 0.7 mm or 21 gauge stainless steel wire. Whereas Roberts retractor 0.5 mm or 23 gauge stainless steel wire. Mills retractor 0.7 mm or 21 gauge stainless steel wire. High labial bow 0.9 mm or 20 gauge stainless steel wire. Right? I hope this information is helpful. Now let's move on to the next question. Functions of indirect retainer. I'm sure you are familiar with this concept, and I'm very confident that you might have answered this correctly. So indirect retainer, it's a part of removable appliance, removable partial denture, which has a specific function, that is to prevent rotational movement of denture. They say direct retention is to prevent displacement of a denture, whereas indirect retainer, the purpose is to make sure that it retains the denture, right? And let's review some information. As we can see in the illustration, indirect retainer is a part of removable partial denture which assists the direct retainer in preventing displacement of distal extension denture bases, like functioning through lever action on the opposite side of the fulcrum, as you can see in this illustration. So indirect retainer is one which helps direct retainer to prevent displacement of distal extension denture base by resisting rotational movement of denture around the fulcrum line established by posterior most occlusal rest. And as evident in this illustration, the basic function is to prevent rotational movement of denture. Consider the above diagram, and wherein denture will rotate in its terminal abutment axis, left side. So place an auxiliary rest perpendicular to midpoint of the terminal abutment axis, which will prevent rotation and provide indirect retention. So this is a guide for placement of indirect retainer, right? I hope it's clear. Now let's move on to the next topic. So there seems to be a question on melanotic neuroectodermal tumor of infancy, a case-based question. Let's review some information. So melanotic neuroectodermal tumor of infancy is relatively uncommon osteolytic pigmented neoplasm that primarily affects the jaws of newborn infants. In 1966, Borrello and Gorlin, as given in Schaeffer's, reported a case with high urinary excretion of vanillyl mandelic acid (VMA), suggesting a neural crest origin, and they proposed the term melanotic neuroectodermal tumor of infancy (MNTI), as evident in the illustration. Since then, numerous histochemical, immunohistochemical, electron microscopic, and tissue culture studies have suggested or supported neural crest origin and confirmed the preferred term melanotic neuroectodermal tumor of infancy. And more than 90% of these cases occur in head and neck region, most on the anterior part of maxillary ridge. That's the reason why we're discussing the same. Other common sites include skull, mandible, epididymis, and brain. Rare lesions have been reported in shoulder, skin, femur, mediastinum, and uterus. If you need any additional information, you can refer Schaeffer's 7th edition, page 204, or you can just drop a comment. We'll provide you guidance or information accordingly. Right? Okay, now let's move on to the next question. Bilateral condylar dislocation, clinical features. These are the keywords which I received. So bilateral acute dislocation is associated with pain, inability to close the mouth, tense masticatory muscles, difficulty in speech, excessive salivation, protruding chin. The mandible is postured forward and movements are restricted, as evident in this illustration. There is gagging of molar teeth in presence of anterior open bite because of this anterior dislocation. Difficulty in swallowing and drooling of saliva is seen. Patient will complain of pain in temporal region rather than joint and may be extremely apprehensive. The distinct hollowness can be felt in both preauricular regions, because we are talking about bilateral situation, Associated muscle spasm contributes to fixed position of condyles, right? So this is some information in regard to clinical features of bilateral condylar dislocation. Again, if you need any additional information, do let me know. Now let's move on to the final topic, gene associated with Van der Waals syndrome. So for sure, there seems to be at least one patient related to genes implicated in various syndromes. So Van der Waals syndrome, it's a localized to 1q32. And also they have mentioned another gene, 17p11. Let's review some information as given in Schaeffer's. Van der Waals syndrome is an autosomal dominant syndrome typically consisting of cleft lip or cleft palate and distinctive bits of lower lips. We discussed the same in the form of a rap song, if you remember. The Van der Waals syndrome can be caused by deletions in chromosome band 1q32. And the linkage analysis has confirmed this chromosomal locus as the disease gene site. The gene has been localized to chromosome band 1q32. Further studies have raised the possibility that degree of phenotype expression of gene defect at this locus may be influenced by a second modifying gene that has been mapped to chromosome band 17p11, right? So this is some additional information regarding genes implicated in Van der Waals syndrome. If you need more information, you can refer Schaeffer's 7th edition, page number 17. Okay? And also, if you need any further clarification regarding any topics discussed in this video series, just drop a comment. We'll update relevant information in the description part of the video within 24 to 48 hours. So I hope the information provided in this video is helpful and your feedback is always welcome. And for any further assistance, you can always get back through mail at proudtobedentist@gmail.com. And also I hope you guys are preparing well for the upcoming entrance. So just believe in yourself. The final days, it's more about staying positive and oriented. It's not just about the number of revisions. Have this perspective in mind, and those who stay positive and oriented will do much, much better than those who are constantly worried about the result or output. So wish you all the best. Love you all.